to welcome you and to introduce our guest speaker so that we can give as much time to Dr. Savitz as possible. For those of you I don't know, my name is Nancy Cass. I'm with the Berman Institute of Bioethics. We are so pleased that today's seminar and the entire visit of Dr. Lucy Savitz is co-sponsored not only by the Berman Institute but by InHealth. Scott Zeger is here. Johns Hopkins University has a large initiative on InHealth. If you don't know enough about it, grab Scott afterwards and he can tell you more. But we love partnering with other groups because ethics so often overlaps with a substantive interest elsewhere. So let me tell you a few things about Dr. Savitz and then turn it over to her. Dr. Lucy Savitz is the Director of Research and Education at Intermountain Healthcare in Utah, and I imagine we're going to hear a lot more about that. She also, relevant to some overlaps here, is the Director of the CTSA Patient-Centered Research Methods Core at the University of Utah. She has served previously as the Senior Health Services Researcher at ACT and also at RTI International. She was the economist at the Colorado State Legislature and a financial planner for UNC Healthcare. She really brings expertise both in health services research and in health economics. Now to this model of integrated healthcare that is put in place by Intermountain. I guess I'll say on a more personal note is really one of the reasons for having invited Lucy. Both Ruth Faden and I were participants with Lucy and about 20 other people at a meeting hosted by the Institute of Medicine earlier this year related to a little slice of the learning healthcare system challenge, which is IRBs and ethics oversight. And Lucy had such great things to say that we thought we've got to get her here and hear more. So I'm not going to say more. I'm going to turn it over to Lucy, but we're really glad you're here and thank you.
Can everyone hear me all right? And I think there's some chairs up here in the front. I see some people standing in the back. Please feel free. So I have a very eclectic background. I am not a specialist in bioethics, but I have been dealing as a health services researcher in an organized delivery system with a lot of the challenges. And I'll talk to you a little bit about the things that I see from my vantage point. So how many people in the room know anything about Intermountain Healthcare? Quite a few. Quite a few don't. So bear with me as I go through this a little bit to give you context. So for those of you who've never been to the West Coast, Utah is this state right here. And we actually have a horrible inversion, so it's fabulous to be in Baltimore where I can actually breathe outside, literally. Intermountain is a fully integrated delivery system, and it's based in Salt Lake City, Utah. We have 22 hospitals that are largely located up and down the I-15 corridor that runs up and down the state. We do have one hospital that's located in southern Idaho, and we have a little over 180 outpatient clinic settings. There's this mythology that we employ all of our physicians and we just tell them what to do and they do whatever we say. That is a myth. It's not true. We only employ about a third of our physicians and even they don't listen to us. But we are the dominant healthcare provider, so we provide a little over 60% of the healthcare in the state of Utah for a population of about 2.9 million. And before I came to Intermountain Healthcare, I was at UNC Chapel Hill. I worked at the Sheff Center for Health Services Research, did a lot of work in rural healthcare. And many of you may know that North Carolina is the third most rural state based on number of people living in rural areas. However, nobody in North Carolina lives more than 25 miles from a hospital. In Utah, we have real frontier areas where you have to go a really long way before you see any kind of healthcare facility. The thing I like, and one of the things that attracted me among many to Intermountain Healthcare, is this population perspective, almost like a public health perspective that we're able to take in a lot of the decisions that we employ. And I can talk a lot more about that if you're interested. But the other thing about Intermountain Healthcare that's incredibly attractive is this notion of a learning commons that's really been driven throughout the entire organization, starting with the very directive strategies of our mission, where our mission is really to serve as a learning healthcare organization and to drive performance excellence. And so not only is it requisite that we provide evidence-based care, but also that we learn from the care that we're providing. so that we're providing the best possible care to our patients. And when we talk about Intermountain Health Care, it's really important to think about this sort of three-legged stool which props up our ability to do what we do basically. Brent James, who is actually my boss, is a world leader in quality and safety, and he developed in the 1990s a quality improvement training program, and we've trained over 2,000 people worldwide, including all of the senior executives and mid-level managers in Intermountain Healthcare, so that everybody has a common language. It's helped shape our culture. Everybody can read a statistical process control chart, even on the wards. And we have something now called 100% participation, which is a series of 5 20-minute DVDs, so that we put the tools and concepts of quality improvement into the hands of frontline workers. And they know that 95% of their job is to do their job, and 5% of their time is to think about how do I do my job better. So it's part of their role and responsibility. And then in the 1990s, two visionary physicians, Brent James and Dave Burton, created something called clinical integration, and they did a key process analysis of all the processes that are involved in delivering healthcare. And they identified about 90% of the effort of a healthcare delivery organization is centered around 104 key processes. And that was clustered down to about 9 areas. And they're sort of akin to service lines like primary care, surgical services, oncology services, women's and newborns. But what's different is that there's an organizational structure built around that. So each clinical program has a physician lead, a nurse lead, a data manager, and a statistical analyst. And all the statistical analysts who are at least master's level statisticians are based in the Institute for Healthcare Delivery Research, which I direct. And so 1/3 of their time is to the clinical program, or 2/3 of their time is to the clinical programs, and 1/3 of their time is to the Institute. And what that does is provide a home base for those analysts, but also gives us a research arm into the clinical programs. And so my role and responsibility is to help turn problems and issues or barriers that the clinicians encounter in delivering care in those clinical program areas into testable research questions. So how do we learn from these issues that people are encountering? And then underscoring all of that, and last but not least, are the information systems. You know, when I first started reading about Intermountain Healthcare in 1998, it was my dream to go there. It's sort of like a dream for a health services researcher that you could possibly have all that kind of data. A single EMR, with historical data. We have about 15 years of historical data that covers the full continuum of care. So it's been really meaningful. The core functions of the Institute, and I'm going over this background for a specific purpose because it's going to link into what we're talking about. But our core functions are quality improvement training, as I've already said, to establish the culture for our organization. And then we have the clinical program support through this clinical integration initiative that I've talked about. And then the other thing that we're really responsible for is to support delivery system transformation. And so at Intermountain Healthcare, we chose not to be an ACO, an accountable care organization. There were poison pills in the way CMS put out that legislation. So we created something, and it's kind of like an Intermountain thing that we always have to do something different and name it something different, so it's the Intermountain way. But ours is a shared accountable organization. And we thought that it was really important that patients had a role and responsibility in their own care and wellness. And that's really threaded through everything that we're doing. We received, and I'm the director of one of the CMMI Innovation Challenge Awards, and in that award we have 3 pieces. One is changing the way we pay physicians, the second piece is looking at patient activation, and the third piece is on population management, all towards achieving the triple aim and helping transform healthcare. And then we have to conduct operationally meaningful research, and I'll talk about that in a minute. And then a responsibility as a model learning healthcare delivery system to disseminate and collaborate beyond the walls of Intermountain Healthcare. And so when we think about our priorities for quality improvement or research at Intermountain Healthcare, this is actually the working list that we use. And I would have to say that about 90% of what we do falls into level 1. And that's that research that has high operational utility. Does it affect the outcomes of the patients that we serve, or the efficiency by which we're able to provide those services? So that's what we do. And we don't really think of that as research. It's clinical effectiveness. It's quality improvement. And then the second level is of interest to the clinical investigators, and it may be a clinical investigator who, just has a research question that has come to mind, or they've looked at the literature and they don't really understand it. It may or may not have a direct influence on the way care is provided, at least immediately. And then those things that are of interest to close partners, and I'll talk more about some of that. And then lastly, external investigators who just want to come and basically take our data. Somebody from Harvard calls up and they want our data and they're going to go away and do whatever. I'm sure it happens here too. And the issue here is, for us in the Institute, is considering the motivation of the nature of whatever it is we're going to be looking at. And so we see, if it's directly affecting operations, that it's really outside of the purview of IRB. And please believe me when I say that I understand, and I'm sure many of you have read all the background research on the Belmont report, and we know why it's incredibly important. And on these hallowed grounds, I was telling Tracy when I walked over here, the first book I assigned for our book club for the Institute was The Immortal Life of Henrietta Lacks, which is almost cliche in this room, I'm sure. But I fully agree about the need for institutional review board. But when it's directly affecting operations, then I'm going to make this case for you about why we see it outside of the purview of IRB, because we have other controls in place to protect against that. The other thing is that there's a role and responsibility for a healthcare system that learns. So we require that there's a sustainable system, and that's what the Institute provides at Intermountain Healthcare, that gets the right care to the right person at the right time. And that's what that operational utility research is all about. And then how do we capture the results from those improvements that we've demonstrated, and then share those results on a larger scale to drive large-scale improvement. This is the definition for quality. And I'm not going to read it to you, it comes from the Institute of Medicine. But it bears thinking about in the context of getting the right care to the right person at the right time. So you ask, what is quality? And quality is really the difference between the care that we deliver right now today and the care that we could be delivering. So David Eddy, who is sort of the god of evidence-based medicine and does a lot of work with us at Intermountain Healthcare, said that the belief that an ethically founded clinician-patient relationship guarantees best care is not scientifically tenable in today's complex care delivery environment. I mean, ponder that a moment. For those of you who are physicians in the room, you're thinking, whoa, wait a minute. But care delivery falls short, and it's documented of how we've fallen short of our potential. So there's well-documented massive variation in practice. You can look across the country, you can look even within a single institution, and you can look factually even within the way a single individual physician or other clinician performs over the scope of a single day. Alan Morris, who's an investigator, and he's a pulmonary care, critical care physician at Intermountain Medical Center, our flagship hospital, did an analysis in the early 1990s where he looked at his own care delivery in the ICU over time and saw degradation in the decisions that he was making over a single day. So a lot of the things that we've tried to do are really based in the work of Dr. Deming, and how do we reduce unnecessary variation in care. There's high rates of inappropriate care that range widely depending on the condition that you're looking at, unacceptable rates of preventable care and associated patient injury and death. I'm doing a lot of work in this area. I direct one of the hospital engagement networks, and we're working with 96 hospitals across the United States to improve safety in 10 areas. There's a striking inability to do what we know works in healthcare. And you've seen the work by Elizabeth McGlynn and others that have shown the lack of preventive care that's being delivered to patients. And then huge amounts of waste. Brent and I did a study. In fact, I'm giving congressional testimony on Wednesday about a study that we did. It was finalized in 2006 on the cost of poor quality and waste in healthcare. We estimated that there was about 44% waste in healthcare. So for those of you who need a reminder, this is a working definition of ethics. But when we think about ethics in this context, we're looking at how do we create a framework that actually reduces risks? And then the thought is, what are the sort of broad categories of risk that we should be considering? And so obviously one is risk to privacy and confidentiality, which we want to avoid. The second is risks to mental or physical harm that the patient might encounter. And a third one that's newly emerging, which was a surprise to me, and we were just talking about this a little earlier, is this risk of abandonment. And there's actually, if you haven't seen it, the February 2013 issue of Health Affairs is a really nice compilation of articles that deal with patient engagement. And there's an article in there that specifically talks about this, but I've noticed that IRBs across the country are starting to look at this, particularly in the sense of shared decision-making and patient activation. As we sort of ramp up those efforts, there's a perceived risk, they think, on the part of patients that we might abandon their care if they're not compliant with that. So it's not really well sorted out, but it's something to think about and something I've never crossed my mind as I'm deploying these large-scale shared decision-making and patient activation interventions. In general, though, many people argue that quality improvement differs from human subjects research in both its purpose and scope. And I want to remind you that healthcare delivery organizations have explicit legal and regulatory requirements to monitor and manage care delivery systems to maximize performance. And we do that through quality assurance and quality improvement. And so we are required to do these things. And I'm not going to go over this slide. It'll be in there, but these are just sort of definitions of quality assurance and quality improvement. So you can see the sort of monitors and controls that we already have in place. But when you think about quality assurance, you know, there's credentialing and privileging. You know, there's case review, M&M conferences, infection control, informed consent to specific clinical treatment. So we've got things in place. And we've got things in place that work. You know, in electronic medical record systems, there are audit trails, so we know who's looked at the information and are they appropriate people that have looked at that information. Understand that in HIPAA, both QA and QI activities are considered part of healthcare operations. They are defined in the law as healthcare operations. Our oversight agencies, the Joint Commission, CMS, require that care delivery groups put in place both QA and QI systems. And there are many professional efforts that track care delivery. So NISQIP is one example, and there are many others, Vermont, Oxford. But the idea is that we are required to do that. And you'll see among the boards, physician boards, there's a requirement, an annual requirement for maintenance of certification for physicians to do quality improvement. And so the basic premise here is that it's our responsibility as delivery systems when we find defects resulting from either QA or QI that we are required to correct those defects. And so there are regulations and there are requirements already in place is the point in the case that I'm making to you today. And the Hastings Center actually came out with a report that was funded by the Agency for Healthcare Research and Quality, or AHRQ. It was a 3-year study. There are all kinds of very senior level, thoughtful leaders who participated in that discourse. And it was published in 2006, and here we are in 2014 talking about it still. And I can tell you my own organization only sort of got up to speed with it about a year ago. But really that QI is an integral part of good clinical practice. This is not, you know, rocket science, and that it's not human subjects research. And again, we've got these two controls that are in place, and they were called out in the report, and so I've talked about them a lot, but really the prevent controls are the IRB largely. The detect controls are the enforceable policies that we have in place as an organization, and that everybody who's employed in that organization is subject to. And I won't sort of read through this list, and I certainly won't read through this slide, but again, you'll have these slides available to you. The thing that was really interesting in the Hastings Center report that came out in 2006 is when they were asking the question of what designated research that should go to an IRB versus not go to an IRB, it came down to conflict of interest. Would there be a conflict of interest on the part of the care delivery team or the organization by withholding treatment for a patient, for example? It wasn't about the ability or desire or intent to publish. And I can tell you, it took my own organization and many bioethicists coming and meeting with our IRB and our IRB leadership to actually convince them that intent to publish is not a criteria for the need for IRB. Now, this is one area that's very contentious in our field because many journals still require it. And so some IRBs have made provisions that you can retroactively go back for review if you are going to later publish the results of your research. But I would argue that morally and ethically, if you do something that works, you have a responsibility to share that with the field. Because one of the questions is, will it play in Peoria, or will it play in Baltimore? You know, if I do something in Salt Lake City, Utah, is it something that you could adopt and adapt here and make it work? And that's a question, and that's why we go to the peer-reviewed literature, so we can sort of put it out there and make it available to people so that we aren't reinventing the wheel. This is a quote from Brent James, who really views this notion of quality improvement and clinical effectiveness research in the context of what our requirements are in delivery management. That we're not really creating new scientific knowledge, but what we're doing is providing care better to the patients that we serve. And again, you know, it's hard to believe how long it takes this giant ship to shift in the waters. Because if you think about the 3 reports that came out from the Institute of Medicine, the first report was To Err is Human, which probably everybody has seen, and you've seen, you know, that we talked about a lot. The second report was Transforming the U.S. Healthcare System, which this diagram comes from, and then the third is Creating a National Healthcare Quality Report. But in this one, the thing that I would suggest that you take a look at is this requirement. So we have this, you know, information-rich, patient-focused enterprise, and we think about how we use that information to make it actionable. But I think the real future for us to think about, and what I'm driving at Intermountain, which for the first time we're going to have a vendor-based EMR, and everybody's sort of scared about this. We've decided to go with Cerner, which is being implemented this summer, and everybody's scared to death. But what we're trying to build in through the innovation is how can we do research as we're going, as we're providing care. And I know the VA has really been a front runner in this particular area, but the evidence being continually refined as a byproduct of the healthcare delivery so that it's not separate, it's not a separate activity. And I can tell you, when I first went to Intermountain Healthcare, they'd say, oh, she's the researcher, and just put her over here kind of thing. We don't do research, that takes away from patient care. And the culture has changed, and they don't use the word research. They'll talk about discovery, or they'll talk about, how do we know this works, Lucy? You know, and so it's incumbent upon us, because one of the things we've done in quality improvement is we put something in place because we think it's the right thing, but we never evaluate it. Do we have the intended outcomes that we wanted? Are there unintended consequences of whatever we've put in place? And these are important considerations for us to know and understand, and it's incumbent upon us to create that infrastructure to make it happen. So we're trying to take that to a next level, to move beyond some of the retrospective and prospective studies we've been doing, but to actually make it more real time, so that we're learning as we go. So the case for continuous improvement, you know, a lot of people talk about quality improvement, and there's an IOM paper that came out, I guess in 2012 now, that I co-authored with Richard Platt and a number of others. And you know, one of the contentions people have said that is if you do quality improvement and it's rigorous and systematic, that makes it research and makes it subject to IRB. And Don Goldman from the Institute for Healthcare Improvement, who's a senior vice president, you know, on our call said, well, you know, there's a lot of crappy QI out there. And there is, you know, even at my own organization. And it's when we don't do it systematically and when we don't see it as part of an evidence chain that we break down and we waste resources. And so we have to really change the way we think about quality improvement. And just because it's done rigorously and systematically doesn't necessarily make it research. It makes people cognizant of the fact that there's a handoff in place. And I actually did a panel for Academy Health, the professional organization of health services researchers, where I talked about this, and I'll show you the model in a minute. But in that paper, one of the things we talked about was the scientific approach to quality improvement. And these are really the steps. So when you read through them, clear, measurable process and outcome goals, basis and evidence, iterative testing, appropriate analytic methods, documented results. You could be reading that same list from something that defined research, right? You know, so how do you distinguish those two? So again, it comes back to that issue of motivation. Are we trying to improve operations and the way we deliver care or not? What's that motivation? And that's really the distinguishing factor that we look at when we look at it. One of the things that I'm most proud of in the work I've done over the last 2 years is working with Academy Health to create something called the Delivery System Science Fellowship. And I think we're now 11 major healthcare delivery systems around the country who actually fund these fellowships, where postdoctoral people can come and work in a delivery system because, you know, and I've been on the faculty at a major school of public health, so I'm equally guilty of this. When we train our doctoral students, we don't necessarily train them for how to go do research in a delivery system. We train them to be academic researchers. And there's a difference. There is clearly a difference. It's almost like the difference of living with somebody versus being married and living with somebody. You know? So I can tell a number of you have had that experience. You know? And it's just very different. It's fundamentally different. The perspectives, how you engage people in the research, how you ask the questions, how you answer the questions, how you deliver the results. And so this is sort of my attempt to begin to define what is delivery system science, and I've been working with Brian Mittman at this from Kaiser. And so it's really a rigorous means to promote a learning commons to answer questions and test hypotheses around organizational factors, care delivery attributes, and customer impact. And I've given you some examples of that. But when I try and talk to people in my own organization and others as we're trying to sort of evolve this sort of field, if you will, you know, we see QI as really sort of this handoff into implementation science, clinical effectiveness, outcomes research, and program evaluation. So one of the questions is, sorry, I have a hard time standing still. I hope I don't mess up the camera lady.
It is fine.
In our organization, one of the things that happens to me when I go to Washington, D.C., and I talk to people at ARC, or I come to Baltimore and I talk to people at CMS with CMMI, they're like, well, you can do it at Intermountain, but nobody else can do it. And I'm sure you all have heard the same thing. The question is, when we develop these quality improvement initiatives, how do we determine when they're ready for spread? And if we put something in place, you know, I just told you, I'm an integrated delivery system with 22 hospitals, over 180 outpatient clinics. How do I know that something that I do in an inner city clinic in Salt Lake City is going to work in a very rural Delta, Utah, or Panguitch, Utah, right? And so it's the notion of doing the quality improvement in a systematic way so there can be this handoff. So we begin to think about how do we take it to scale? How do we determine whether it'll work in different kinds of clinical settings with different kinds of capacities and resources that are available to them? And I won't talk about it in detail unless you ask me a question about it later, but one of the things that we pioneered in early 2000 was something called mental health integration, where we put mental health capacity into primary care practice, and we have a cascade model to get the right patient to the right level of care because we, like everybody, have a shortage of higher order psychiatric services. And so, you know, what we've done since then is we've implemented it in Biloxi, Mississippi after Hurricane Katrina in federally qualified community health centers. We've done it in community health centers in New Haven, Connecticut, a rural hospital in Seaside, Oregon. So, you know, the idea is when you have these larger scale tests of change, you begin to build that evidence about how does it work, how can it work, so that it can inform the way we're delivering healthcare. And so that's how we're building the evidence, and that's how we're building the science. And without that rigor from the very beginning, it becomes almost impossible. And I can talk more about sort of the evaluation challenges when you don't build it in at the beginning. Now, when we take it to scale, the idea is, what's the scale we're talking about? You know, are we trying to inform Intermountain healthcare? Are we trying to inform our region? Are we trying to inform the nation, the world? Some might argue we are. There's an interesting article by McCann, Berwick, and others where they really talk about the science of large-scale change and how we're really obligated when we find things to work to get them out there, to make them available. And I'm going to talk to you about a couple of ways Intermountain has done that. And then I'm going to spend a little bit more time talking about some specific examples to give you real hands-on understanding of the challenges we faced in some of the specific projects that we're doing right now. So this lovely graph is my attempt at art. You can tell why I'm not an artist, right? But this is our action network. So I'm the project director for our ARC Action Network. And the inner dark blue circles are our primary partners, and then we have sort of the more affiliated partners that are on the outside of that. We've done a number of studies there, and I'll give you one example from Providence Health System in particular that'll illustrate some of the IRB challenges that we've encountered. But the notion here is, how do we take these projects to scale? And I've led over 36 projects where we've implemented across multiple delivery systems, doing rapid cycle research, and some of it's been IRB. There's been requirement for IRB, and some of it has not. I mentioned to you the Partnership for Patients in the Hospital Engagement Networks, and our hospital engagement network is 96 hospitals that are distributed across 17 states in the United States, and you can see the expanse here in terms of the numbers of admissions and beds, et cetera. And what we're working on is improving patient safety in 10 areas. This is an older chart, but you can see the kinds of things we're making major improvements on. We've seen 40% reductions in Class C SSI and VAP across that network. That's huge. That's huge. When you want to start counting the number of people who don't die and the number of people who don't get sick or don't have complications in healthcare. So we see this as large-scale quality improvement across multiple organizations. And then we're involved in something called the High Value Healthcare Collaborative. How many people have heard of it? Okay, that means I should talk a little bit more about it. The High Value Healthcare Collaborative was dubbed as sort of the dream team. And it had its start when Brent James from Intermountain Healthcare, Rob Nesty from the Mayo Clinic, and Jack Wenberg from the Dartmouth Institute got together and started talking about the challenges and variation in care and how unacceptable it basically was for the quality of healthcare in the United States and the cost of healthcare in the United States. And so they had been working together doing collaborative sort of off-the-books research for about 15 years. And then about 3.5 years ago, they decided to formalize it. And so basically, the Mayo Clinic, Intermountain Healthcare, Dartmouth, and then we brought in Denver Health. And we brought Denver Health in specifically because they are a safety net hospital that also serves the Public Health Authority in Denver, Colorado. Because our idea was to build a network that represented the general population. And the founding principles of the High Value Healthcare Collaborative were that we have to transform the way we deliver healthcare. One, we won't survive if we don't. And two, quality is going to get eroded because of the, just continuing cuts to payment that we are being subjected to, both providers and facilities. And we didn't want to wait for some policy wonk in Washington to come give us some solution that's completely unworkable. And we decided we would build a network that had a strong enough voice that we could sort of carry weight and go to Congress, go to CMS, and get the kind of changes that we thought were important. And so we've added a number of others. I'm not going to read this list. You can sort of scan down the list of healthcare systems that have joined forces with us in doing that. And these are the more recent additions. And I noticed that you've got some relationship with the Department of Health. So TRICARE has come in to work with us as well. And so basically the High Value Healthcare Collaborative, let me just say a couple things about it. Have you seen the publication eGEMS? eGEMS is a new free e-publication. It's peer-reviewed from Academy Health and the EDM, Electronic Data Methods Forum. And there's actually a great article in there on governance structures, and they highlight the High Value Healthcare Collaborative. One of the things that's really nice about the High Value Healthcare Collaborative is that we have a master collaborative agreement across all these organizations. And what that master collaborative agreement does is it establishes principles about data sharing, about intellectual property, about who has access to the data, how do you opt in or opt out of particular projects, but it allows us to share patient-level identified data across all of our delivery systems, which is huge. And our ability, because it allows for centralized IRB, our ability to expedite multi-center studies is tremendous. I mean, it's unparalleled really with any other collaborative that exists currently right now. We currently get the data feeds from CMS that are more up to date than CMS even has access to. It's about a month and a half lag. And the Dartmouth Institute is the data repository for all of that data. And so we're able to link CMS claims data to our clinical data. And so I can tell you for any patient at Intermountain Healthcare, if they got care outside of Intermountain, I know their full history of care. which is huge. My CEO, I have to go meet with my CEO on a monthly basis and tell him the value he gets out of being in the High Value Healthcare Collaborative. And he agrees that just by having access to that data alone, it's worth the money that we pay to be a member. So it's been a good thing. But what I want to do in the next little bit of time that I have with you is to give you 3 specific examples from the field that we're working on right now. And I certainly want to entertain time for questions that you have, because I know I'm throwing a lot at you right now. But the first example is to illustrate the burden of IRB and testing QI interventions. And the example I'm going to give you is an action project from ARC. It's a real project, and we were testing the role of a transition pharmacist at Providence Health and Services. So we were trying to improve medication reconciliation and unnecessary readmission to the hospital. We were targeting very elderly people, people over the age of 65. And the Providence Health and Services IRB gave us a consent form that was, one, terrifying, very long, and in very small font. And we found that in the first 2 months of the study that over 60% of the patients were refusing to be part of the study. So pause for a minute and think about this. We're offering to give you more, better care, and you're refusing it. And it's because of the nature of the way the consent forms are reading. And so it took us another 4 months to get the IRB to agree that we could have an 18-point font summary sheet on top of the consent forms. We weren't going to circumvent the consenting process. But what we wanted was something that so somebody could read it in English with big font in little bullet points, bless you, that basically said, this is what the study's about. You're getting more care. You know, there will be an extra pharmacist looking at your case. And our sign-on rate went through the roof. We had nearly 100% after we added that. And so the notion of a lot of this quality improvement, you have to understand, when we're comparing what we're doing to improve quality in many cases, is better than usual care. And so it's not really a risk to the patient. And again, we have all of these other controls in place to protect privacy and confidentiality, and we're not really introducing risk of harm in terms of physical or psychological potential harm to the patient. So this is one of the reasons that people who do the kind of work that I do in delivery systems find it very difficult to work with IRBs. The other reason they find it difficult, this study was actually replicated in 3 other delivery systems, and each IRB had a different decision, so there's a huge amount of subjectivity. At Intermountain, they didn't require informed consent. They said, you're giving them more better care. Why would you need to have informed consent over this? You know, so the idea here and the cost, many IRBs are starting to charge money to have the proposals reviewed, and many people don't know that, so they don't budget it in. And it can be quite expensive. The time to process IRB applications can be extensive. I know at Intermountain Healthcare, the thing that's really just mesmerizing to me is, you know, drug trials that they'll put in place, they can approve within a month or two. If you put in a proposal where you're trying to do a qualitative research study, I've seen them take 8, 9, 12 months. And there is no intervention into the care. You know, you're just asking people about their care that they've received. So, you know, I think that it's important for us to balance and consider that issue. And then one of the other projects that I'm working on is shared decision-making in Intermountain, and it's a comparative effectiveness study of 2 decision aids. And this is a natural experiment. So what happened at Intermountain Healthcare was our own health plan, Select Health, together with our medical group, decided that they wanted to set a board goal around shared decision-making for our shared accountable organization. Because we saw that as a mechanism to reduce unnecessary surgical services that were being provided and to create a more informed patient population as part of that shared accountability that I described to you. And they looked at all the available decision aids and they chose ME solutions. If you look at ME solutions, there is no evidence base in the literature other than that they can show, there was one study that showed that it improved informed consent, not that it actually improved decision making. But they chose it because they felt like the reading level was more compatible with the larger part of their patient population. Separately from that, the High Value Healthcare Collaborative received a CMMI Innovation Challenge Award that actually was largely focused around shared decision making. And the idea was to implement shared decision making in 5 areas across all these 20 healthcare delivery systems as a quality improvement project. Now, I'm a researcher, so I look at that and I say, that's a natural experiment. And I work in a delivery system that has 6 regions. So I got the medical group to agree that they would only implement ME solutions in our urban central region. And because I was running the study, we would only implement shared decision making in our southwest region, and there's a region in between, so there's no risk of contamination. And it allows us, at the end of 3 years, when health dialogue tools are no longer available, and there is a strong evidence base around the preference-sensitive conditions for shared decision-making using the health dialogue tools, that we would be able, as a delivery system, to make an informed decision about which decision aid is optimal for our patients. By looking at issues related to patient-reported measures that we're collecting, and that's a whole new area, that many of our delivery systems are looking at. How do we collect that data? What do we do with that data? What happens when the data conflicts with other sources of data that we have in place? And actually, when I went to the IOM meeting that was referred to in my introduction, that was what I was asked to talk about, because we see that as quality improvement. We don't see that as research. And there was an objection. I didn't hear any objection from OHRP, and we still haven't. So, and then the last one is shared decision making across the High Value Healthcare Collaborative, which I've alluded to. And so the Dartmouth IRB looked at that, even though it's across multiple delivery systems, and even though we're systematically collecting information and we're trying to monitor the impact of the shared decision making on health outcomes and cost of care, it was viewed as quality improvement, and there was no requirement for informed consent. But again, think about it, you're giving patients more. So the way we do shared decision making in both of these projects is that basically the patients, when they come in to see the physician and they receive the appropriate diagnosis, and the physician says, I think this person is eligible for shared decision making, based on whatever eligibility criteria the clinic establishes, then that patient is given a PIN, and the idea is that they can go home, log into the system, and ask them a series of questions about their values, expectations, and preferences for their treatment. And then depending on the particular decision aid, so if it's for knee replacement, there's the COOS, or hip replacement, there's the HOOS. These are validated tools. We're using the PROMIS 10 as a standard for quality of life. PHQ-9 is in there, and we can talk a little bit about the 9th question and the issues of having that in there if you want. Then takes them to the decision aid, and they can watch the decision aid several times. They can watch it at home with their family members or friends, and then it comes back and it repeats the questions on values, preferences, and expectations of their treatment. And what can happen, because it's done on a computerized platform, is the care manager in the clinic, or the medical assistant, depending on who's assigned in that clinic, can see the progress the patient has made. Have they started it? Have they completed it? Is there a decision conflict that occurs, that they change their mind in between? And all of those individuals in the clinic who've been designated as health coaches have received training, and they do motivational interviewing. So if they see there's decision conflict, they'll call up the patient and they'll say, Mrs. Jones, we notice you've changed your mind. Do you have any questions? And they sort of go on with the motivational interviewing. So that when the patient comes to the clinic, it takes the discussion to a whole different level. None of that basic education is happening anymore in the clinic. And so the physician can work with that patient to think about what's the appropriate treatment plan for that particular patient. I can't tell you the testimonials that we've had, both from providers and from patients and their families. Because when you think about it, when you go to a clinic and they give you information, a lot of times you may hear it and then you forget it by the time you get home, or there may be a significant other that should have heard that information as well, and they weren't there, so they didn't hear it. And there's certain things that you don't even think about at the time, and I know there's certain things that the surgeons don't discuss with you. I tore the meniscus in my right knee 2 August ago, and I I went to the clinic and they scheduled me to meet with the surgeon at Tosh, our orthopedic hospital, top-notch orthopedic hospital. I was scheduled to get an MRI the next day. And on that day, I had all the shared decision-making experts in the United States in my condo drinking wine. And they were all hitting the table saying, no MRI, no MRI, no MRI, because it meant I was on the path to get surgery. And they said, did you think about this? And never, a top-notch facility at my own organization, never once did anybody talk to me about what it would mean to have the surgery and how I would or wouldn't be able to ambulate and what would the rehab look like. Well, I live alone. I walk to work. I drive a stick. I would have had to make arrangements to either go someplace else to recuperate or have somebody come and live with me for a period of time so that I could get to work and do those things. Otherwise, my outcomes would probably deteriorate because I'm a terrible patient. Ask any physician who's ever treated me. I'm sure I'm out there walking when I'm not supposed to be. I'm out there doing what I'm not supposed to be doing. So, the idea that there could be a medical or a physical therapy intervention was never discussed with me. And it doesn't mean I necessarily received bad care. It's what happens in the context of that. I'm sure I was busy. I'm sure I walked into the physician's office and said, okay, I got 5 minutes and then I've got to be at a meeting upstairs, kind of thing. So I'm sure I'm partly to blame for that experience. But the point is whether, you are, of sound mind and not in a crisis situation and you can interpret that information, assuming you have the right time, you may not think about those other implications for the holistic treatment of your health. And so, we think that the shared decision-making is really an important way to improve the quality of care that we're providing to our patients. And it's a part of the operation. So hopefully that sort of brings it back full circle for you. We've got this long history of collaboration in a learning commons. Intermountain is really committed to this idea that we share what we know. You can go to our website, you can download our care process models. Anybody will come and talk to you and share with you about those. So I'm going to leave you with 2 things. 1, a song in your head. The times they are changing. And 2, this idea that there is an Academy Health fellowship in delivery system science if you're interested. And there's some select references that are here. So with that, I'd like to know if you have any questions. Thank you.
Fine for you to field your own questions? And we probably have about 15 minutes for questions. So.
Questions? Or did I just bore you to death? Yes, sir.
You said that the decision aids are provided through the internet, right? What about patients who don't have access to the internet or are not comfortable with it?
Right, so the question is, I said that the decision aids are provided through the internet, and the question is, well, what if you don't have access to the internet? There was a U.S. Census study that was done, and it was released about 9 months ago now. And basically, over 85% of the population in Utah, and you would be surprised looking from state to state, has access to the internet, either directly or through a family member or friend. Our backup plan, though, because you should always have a backup plan, is twofold. One is we have iPads in the clinics, and so if you have no access to a computer, either through a family member or friend or your public library, you can come to the clinic early and view it on the iPad in the clinic. The other option is we have like a Netflix kind of option. So there's a hard copy of the written materials and then a DVD that you can take home and then return. Does that answer your question? Yes?
So, 2 questions. Thanks for the talk and sharing your experiences. The first relates to your example that you gave about the first of the 3 studies you described, in which you attributed the low response rate to the fact that it was due to the consent form.
Mm-hmm.
Do we know that?
Yes, we do.
And it was questioning how we know that it was a fact and not correlated with the fact of the form.
So one of the things that we did when we met with the patients, just in the first week we noticed there was this huge amount of resistance. And so we decided that at the end of the consenting process, if people refused, we asked what was your major reason for refusing, and so we documented that. And we were able to then take that to the IRB as evidence that we should be able to put on that form, and because people said it's really hard to read this and I can't see it, and so that's how we got them to let us do the 18-point font, and there's just so much here, and so we got them to agree to put bullet points on the front sheet. And again, we weren't doing away with the consenting process, we just put that on top of the consent sheets in response to the feedback that we got.
Thanks for clarifying. A couple times you mentioned that a justification for not considering disease research is that you were doing more for patients who were getting more care. And I'm just questioning that because we know that there's a disutility of information as there can be utility of information, and there could also be not all care is good care, and more care can be bad care.
Right.
Since if you give someone with emphysema too much oxygen, you kill them.
Yeah.
And so the question is more better and how you
Yeah.
improve that issue.
So it's not really the justification for it, although I would say that the risks are reduced when we're giving them better care. So in the case of medication reconciliation, if we're having an extra pharmacist look at their record, I would say we're giving them more better care. In general, more care is not necessarily better, and I'd be one of the first people to argue that. What we're saying is, and the justification I've tried to make, is that quality improvement is not research because it's part of operations. And we already have policies and protections in place to monitor. That's the case I've made. Yes, sir?
Could you expand on that in the operation sense of what the protections are and the oversight?
Sure.
Good.
So think about any of you how many people work for the healthcare delivery system? Not many. Okay. Well, if you become an employee at a healthcare delivery system, you have to sign a whole slew of papers about your roles and responsibilities with respect to privacy and confidentiality of the patients, the appropriate way and who can use and look at medical records. And then I don't know about your organization, but at my organization, there's an annual training program that you have to go through and certify your HIPAA compliance, and there are a variety of other compliances that you have to certify. And so there is an annual training and documentation of that. And there's an audit trail on every electronic medical record viewing. So say, for instance, I don't know, President Obama gets admitted to Intermountain Healthcare. If I went on and looked at his medical record, it would be inappropriate. I'm not a clinician. I have no business looking at that medical record. There would be an audit trail, and the policy is if you inappropriately look at a medical record on the first time you do that, you are fired from the organization. So those are the kinds of things that I'm talking about.
But when you say that something's an improvement,
Oh,
so
okay.
who makes the judgment that indeed the proposed QI is an improvement versus, is there a body that does this?
Yeah.
Is it a hierarchy?
Yeah, so there are two ways that it happens, and it depends on the origination of the effort. So there's the clinical program infrastructure that I already talked about, and there's leadership guidance council. And those projects, if it comes from the clinical program, because we do a lot of grassroots improvement, that would be viewed and vetted through the guidance council, and the guidance council would make a determination, is this quality improvement or not? Does this directly relate to operations? Separately, in the Institute for Healthcare Delivery Research, there is a leadership council, and it's Brent James, myself, and Todd Allen, who's the Assistant Chief Quality Officer. Brent James is the quality officer for our healthcare delivery system. And so if it's coming through the Institute, that's the determining body. And please believe me that we err on the side of conservatism. If there's ever any question, it goes to the IRB, and I'm not here to say that we should do away with IRBs. They serve a very important purpose. Yes, sir.
I want to ask about measurements. So your case study, your personal case study of the decision you made involved some variables which were your characteristics. And there are many characteristics like that that affect health: smoking, exercise, diet. I wonder if Intermountain has a systematic way of capturing health contributing, disease contributing factors that don't typically come up in the clinical setting.
Yeah, so we're now talking about patient-reported measures. And I think our delivery system, like most delivery systems, are in its infancy in collecting such measures. And I can tell you the biggest struggle I'm having, because I'm leading that effort at Intermountain, is with our compliance department. And I hope I don't offend anybody in the room, but compliance people usually start with no. And I always tell them, well, I'm a child of the 60s, and I don't want to harm anybody, I don't want to break any laws, but tell me how I do it, within the system. Because patient-reported measures are really important. And so I described the CMMI Innovation Challenge Award with the High Value Healthcare Collaborative. And we have something called an SAT platform that was created by Dynamic Clinical Systems, And they're also partners with Cerner and many other delivery systems. They've just done a big initiative with Virginia Mason. And so through that initiative, we are currently collecting patient-reported measures, so related to physical activity, related to quality of life, related to diet and nutrition and a bunch of other things. They worked and took that same tool and implemented it through the patient portal at Virginia Mason. And that's what I'm trying to do at Intermountain, is to implement it through our patient portal, which is called My Health. And then the clinical process would be in the clinics. The clinics would advise the patients to please go and enter this information because it's important in your decision making. And then that information would flow into the electronic medical record. The one contentious area is PHQ-9 and how do you handle that, because the 9th question is about suicidal ideation. And one of the things that I've done in prior, actually real research projects, is that we've eliminated the 9th question. In the SAT tool for CMMI with the High Value Healthcare Collaborative, they've left the 9th question, and if a patient picks that 9th question, then basically there's a big red thing that says, please call 911, whatever. But I think there's still some question of liability on that. So there are ways in which people are trying to do it in secure environments, is the answer to your question. Yes, sir?
Yeah, just going back to the liberalizing the oversight for IRBs, and accepting for the moment that the exclusive disjunction between research and QI is defensible, it seems to me that the argument for treating them differently, the IRB, or treating one for the IRB, either proves too much or proves one thing, because it seems like when you argue, what you showed us was that IRBs can function subjectively. You mentioned, I think, some diversity in how IRBs function, so there's no limit of subjectivity. And even in this case, when you went back to the IRB, they corrected themselves. So IRBs can function poorly. But it seems like they're functioning poorly on their own terms. That is to say, this is a general problem with IRB that would be a problem even for how they approach research. And it really would militate for correcting IRB function so it works well, whether for research or for QIs. And when you make the point about the subjectivity of a council or a board, that point seems so general that it would also implicate these sort of guidance councils and things like that. And one of the reasons for additional oversight bodies is that anybody has an element of subjectivity or capacity for functioning. So creating a redundancy in the system, so those are overseen, would be helpful.
Yeah. Well, I think the way that we, and I'm using a global we here, a lot of us are speaking on these topics globally, and the IOM meeting that was referred to in my introduction is, for the first time in 30 years, we're revisiting the common rule. And so what we're asking for is that there's more explicit direction within the common rule about what is QI and what's not QI, what is subject to IRB purview and what is not. And there are whole areas that have never been covered under the common rule that it's being expanded. So I think we're trying to do that, and we're trying to do that in a more global way as well. The gentleman in the last, and then we'll sort of move on.
In other aspects of research, there's greater and greater concern about unpublished findings, right? That we make the wrong assumptions because of unpublished findings. How does that fit with QI, where it doesn't go through an IRB, does not have a formal protocol, does not create any incentive for publishing either the report or the existence of it? And I have a real problem thinking how that's going to work.
Yeah. Well, a lot of us who've been doing quality improvement for a long time have a real problem even trying to get our work published. And so there have been a number of journals that have been created that start to look at quality improvement projects. I know at our own organization, they've created sort of a 4th level of approval, which is a retrospective review. So if you've done a quality improvement project and you think that it should, contribute to more generalizable knowledge, you can go in and get that approval, because some journals, even if it is QI clearly, will require that there's been IRB approval.
But the notion of going back when you have something that works is the problem.
Well, no, I agree. I agree. Yeah, I'm not meaning to suggest that. Maybe I'm misspeaking and not being articulate. When you have something that's worth publishing, there is a huge bias in our literature where people tend to only report positive findings and they don't report the negative findings. And I would agree with you on that. The biggest problem we have in our organization is that most of the people who are doing quality improvement are not, they're clinicians, they're busy clinicians, they're nurses, they're pharmacists, they're physical therapists, And for them to take the time to try and publish, and when they've never published before and they don't have a mentor to do that, that's one of the biggest struggles we have, is in that resource capacity, and how do we support them in those publication efforts. So I would agree with you wholeheartedly. We shouldn't just be publishing positive results. Yes, ma'am?
So maybe the last question.
Genetic information, is it treated any differently than any other kind of information? So when
See, this is one of those whole new bailiwicks that, you know, we really haven't dealt with, and that's one of the areas of the common rule expansion that's being dealt with.
But even procedurally,
Right.
when blood is drawn, what happens to the blood? Does it go to a database where anyone who has access to the medical record has access?
Not anyone who has access. The only people who who should have access to the medical record to look at a certain patient's viewing are those people who are involved in the care delivery process. Except for one of the things that we've done as a healthcare organization, and it's actually argued, I think, in the paper that you guys published, that if, as a learning healthcare delivery system, you've let your patients know that their retrospective data could be used in trying to improve the way you deliver healthcare as a learning healthcare system. Did I get that right? That basically, that there is an expectation that those clinical values could be used in retrospective studies.
Great. I'm really sorry to have to do this, but we always promise everyone that we'll get you to your next meeting or class on time. So we're going to end here, and help me thank Dr. Savitz for her presentation.